Welcome to the FMP Essentials Show. I am Dr. Yousef Elyaman, your host, and I am thrilled to have you here with us. Whether you're a seasoned functional medicine practitioner or just starting out on your journey, this show is going to be a go-to resource for mastering functional medicine and making a real impact in your practice and community. Thank you for joining us on the FMP Essentials Show.
Disclaimer: the information presented in this podcast is for educational and entertainment purposes only. It does not constitute medical advice and should not be used to diagnose, treat, cure, or prevent any disease or health condition. Any statements or claims made about specific supplements, nutrients, or other products have not been evaluated by the Food and Drug Administration. Supplements are not intended to diagnose, treat, cure, or prevent any disease. The views and opinions expressed by guests on this podcast are their own and do not necessarily reflect the views of the host or producers. We are not responsible for and do not endorse any statements made by guests. Listening to this podcast does not create a doctor-patient relationship and does not give listeners the right to practice medicine or provide medical advice to others. Only licensed medical professionals can legally practice medicine or provide medical advice. Always consult with a qualified healthcare professional before starting any new diet, exercise program, or supplement regimen, especially if you have a pre-existing medical condition or are taking medications. By listening to this podcast, you agree that you understand and accept this disclaimer. Now get ready to dive in and enjoy the show.
Hello, everyone. Dr. Yousef Elyaman here. Welcome to the FMP Essentials Show. I'd love to welcome a good friend of mine, Dr. Ellie Campbell, to the show. Dr. Campbell, give us your 76-second bio.
Hi, everybody. I'm Dr. Ellie Campbell. I'm a board-certified family physician for nearly 40 years, and I'm also double board-certified in integrative medicine and have done the holistic integrative medicine training too before that board shut down. So I have a solo concierge-style medical practice in suburban Atlanta. This is our 19th anniversary, so we're now in our 20th year as of August. I was an early adopter of direct pay primary care before there really was a model for it, and I've had no insurance practice in a brick and mortar building for 20 years. Specialty has become cardiovascular risk reduction. I'm thrilled to report we're in our 9th year with 0 heart attacks and 0 strokes for any patient that follows our protocols.
Amazing, amazing. And I think since I know you and I know a little about what you do, people are not going to want to skip around or miss this, especially some of the twists that they're going to hear today, connections that you probably never thought of before or you never knew existed. And especially stay tuned for the end, because what you do in your practice for giving back is remarkable. So let's start with our topic at hand, hypertension. So why is it that you chose the topic hypertension to speak about?
I am a functional medicine physician, and like every one of us, we practice therapeutic lifestyle changes as a cornerstone of treatment. And I wanted to start writing a book about therapeutic lifestyle changes, but it's really boring and it's been done 100 times. And people don't want to get beaten over the head again with eat clean food and drink clean water and exercise and pray and meditate and spend time in nature and all the fundamentals. Along the way, I had a horrible experience that shifted my career forever. I'll tell the story very briefly. Dee was 76 years old. She was a spunky grandmother. She was brought to me by her daughter who had been infertile, and I helped get pregnant at age 42 and have a baby, and everything was wonderful. And she wanted grandma to see me and have her hormones balanced as well. So we took care of her hypertension and her high cholesterol and her hormone balancing. And one day Dee had a horrible hemiparetic stroke. And I felt gut punched because I was her primary care doctor. It was my job to protect her against this, and it happened anyhow. Make a long story short, Dee had that dreaded complication of hemorrhagic transformation, and she developed a brain bleed a week after her stroke, and she died. And so I made a pact to myself that I would do everything that I could to learn everything about what might have caused that stroke and what might have I done to prevent it so that it could never happen to anyone else. And that brought me through to the Bail-Donine program, where I learned about preventing heart attacks and strokes. And the thing that rattled my cage that really changed the trajectory of my career was understanding the oral and systemic connections. And I called her daughter up. This was about 3 years after her death. And I said, Cheryl, I think I may have figured it out. Before your mother died, is it possible that she had a dental problem? And she said, yes, as a matter of fact, she was fighting a toothache. She was scheduled to have her tooth extracted the week after her stroke, but she never made it to that appointment. And I was like, I knew it. I just knew it. If I had known more about the dental, oral, cardiovascular connection, I might have been able to prevent this event. So then I decided I wanted to write a book about oral systemic connections. And I wanted to bring this message about oral systemic health to everybody. And I started writing it, and I had this book all done, and we pitched it to a publisher, and 83 publishers turned me down. Nobody wanted to publish this book. They thought it was really boring and not interesting. So I went on Google and I started researching what is it that people do want to learn about regarding their health. This is in the pre-COVID days. And for 10 years in a row, blood pressure came up in the top 10 searches on Google for health. So I decided to write a Trojan horse. I decided to write a book about oral systemic connections and therapeutic lifestyle changes under the guise of hypertension. And that way people would pick it up and actually read it. And I would drill into their head the things they needed to know under the guise of what they wanted to know.
And now that secret is out, and your book is doing successful, right?
It is, yeah.
How, apart from the oral connections, the diagnosis, hypertension itself, how important do you think hypertension is?
I think it's probably one of the most underappreciated, because even doctors think it's boring, right? We don't take blood pressure ourselves. We delegate it in most offices to somebody else to take for us, not appreciating the true value of what their number is. And I think vital signs are vital, and they need to be done properly. And they're done wrong 90% of the time. In my journey writing this book, I learned I was measuring blood pressure wrong, and I was making at least 5 critical errors, and I wasn't standardizing the readings. So the patients were getting the wrong readings, and I'm old. So I was using the wrong numbers for what my target blood pressure should be. So I was under treating and falsely diagnosing people. And it's part of my mission now to teach people the current American Heart Association guidelines for what is proper blood pressure and what is the proper way to check it.
And you mentioned it, it's not like people want that cool kind of, that topic that's out there, that new thing, when a lot of times just getting back to the basics is extremely important. So I teach on the cardiometabolic module for IFM, and we go over risk stratification, we go over cholesterol, hyperlipidemia, and coronary disease management. But one of the things that people miss often is that one of the big risk factors for strokes and heart attacks is high blood pressure, and it's that blood pressure is going to push the particles, the cholesterol, in between the cracks more, and it's going to increase the wear and tear. So yeah, no, hypertension. I think the other thing too, I gave a talk with the anti-aging A4M, the Anti-Aging Institute, about using hypertension and as a biomarker and for its effects for aging. And what a lot of people don't realize is that the higher your blood pressure and the higher you leave your blood pressure high, the higher the aging that is happening to your kidneys, to your brain, to the other parts of the body, right? So no, I love this topic. I know that this topic, we're going back to the basics here, talking about elevated blood pressure. And I think where we really stand apart, for those of you practitioners that are not functional medicine practitioners yet, I think you're going to be in for a treat when you see how we take a look at what's actually causing it. It's so easy to just diagnose something, say they have hypertension, but really all that means is their blood pressure is elevated over a certain amount of time. To us, we're more about what is causing it in the first place? And we're going to go over it, but there's multiple things that can lead to high blood pressure. So that leads me to the next question. How do you diagnose hypertension?
You take a blood pressure. It's as simple as that. But you have to take your blood pressure properly, and you have to get a lot of data, because we shouldn't make a single reading. And this, just like I would never diagnose diabetes with a single finger stick blood sugar in my office, we should always ask the patient to get multiple data points from home, wear a continuous glucose monitor, or get me a bunch of finger sticks from home and show me your trends over time. I think we need to do the same for blood pressure. But the first thing is to check properly in the office. And there's some
Right.
very common mistakes that are made. One is using the proper blood pressure cuff size. Many of us, especially as we age, we get this wonderful extra flap of skin on our tricep region. And when we use a regular size blood pressure cuff, it's too snug on my arm. But if you go to an extra large blood pressure cuff, it's too long for my humerus. So you need to get a proper size. And Welch-Allen sells an adult long blood pressure cuff. So it's the right width and long enough to get around our slightly larger arms. And I think that's a really important thing. There's all kinds of guidelines about how you can measure in millimeters and what the proper size is and all that. But I just think that hack of knowing that there's a adult long blood pressure cuff, that's probably the most used cuff in our office, more than the extra large and more than the regular. So use the right cuff. Next thing, that cuff has to go on the bare arm, not on the skin, not on the sweater, not on the shirt. Depending on what climate you live in, if you're in the northern Michigan area and someone comes in with a sweatshirt or a sweater and you check their blood pressure on top of that, you can get a false reading up to 50 points. So don't make that mistake and falsely diagnose someone with hypertension. And you might even be calling it white coat hypertension when really it's operator error. It's, I did the wrong kind of blood pressure measurement to assign that diagnosis to the patient. The arm needs to be supported. Another challenge, and that is that I am vertically impaired. I'm only 5 feet tall. And so it is impossible for me in most chairs, in most doctors' offices, to get in the right position to have my blood pressure checked. That position is bottom to the bottom, back to the back with my back muscles supported and feet on the floor. If I sit with my back to the back, my feet are dangling. They don't touch the floor. And that is an improper way to measure blood pressure. If my feet are dangling, my blood pressure can be higher, 8 points, artificially elevated. I need to be offered a stool, a step stool, or a box to put my feet on so that my feet can be supported for my blood pressure to be properly tested. That has never been offered to me, ever, in any doctor's office. But we have a stool next to our exam chair. And for some people, they need this. And the big one is empty your bladder first. Having a full bladder can raise your blood pressure 10 to 20 points. And if your bladder is painfully full, that elevation can persist for 3 hours. We want to make sure, in my office, we used to do our physicals. So the patient would come in, we would tell, they'd be seated in the waiting room, they'd be hydrating because they knew they needed their blood work done. They'd be escorted to the exam room, they'd get their vital signs, and then they'd say, all right, now go down to the hall and leave us a urine specimen, put it in the window and the door. Meanwhile, they're holding it, and we've checked their blood pressure with their bladder totally full, falsely getting 10 or 20 additional blood pressure points that they didn't need to have. So now, as soon as they hit the front door, they're sent to the bathroom to give us a urine specimen. And then they come back and get their vital signs checked.
Nice. And great pearls. So get that urine specimen just in case, because what happens, they'll pee and then you'll ask for urine later.
Always get the specimen, yeah.
So maybe we can start a little business here. Maybe we can sell these hypertension little stools, or and maybe charge a little bit more, and we could have a stool that you use to take a nice poop, and also you bring that in and check their blood pressure.
Squatty potty for the blood pressure, right?
That's it. Nice. So no, thank you for those pearls. I think one of the biggest things I see is people just only check one arm, or they have them come out, they're holding their arm up, right, and their arm is not supported. And of course, heart level, right? You want it heart level. Heart level, yep. Which is why the wrist blood pressure cuff for most people is not a great thing to have at home for home blood pressure monitoring, because they hold it down. They're not holding it at heart level when they check their pressures. Tell us about 24-hour blood pressure monitors. Do you use them? Yeah, so I don't. I do if I refer to cardiology because they have them stocked in their office. There is a nice reimbursement code for ambulatory blood pressure monitoring when it's needed. And it's a reimbursable service. But since I have a concierge practice and I don't bill or file any insurance, it would be all cost to me and no profit to me to do that service. Instead, right, just like we can do continuous glucose monitors and get 24-hour data, we can also do finger stick 4, 5, 6 times a day and get a decent picture. We can do the same for blood pressure.
So while we don't do continuous ambulatory blood pressure monitoring, we do frequent home blood pressure monitoring, and I can get a pretty good idea of that, because there's two false things that happen. One is some people have perfectly fine blood pressures at home, but they come to the office and their blood pressure is sky high. These people do indeed have white coat hypertension. But there's also some people, maybe 10% of the population, who has masked hypertension. These are people who are really good at getting their Zen on. They come to the office and they have normal blood pressure readings, but then they go home and they blow a gasket and they're yelling and screaming and throwing plates, and their blood pressure is elevated at home much of the time. And we miss it because we didn't have them check at home. Even people with normal blood pressure in the office should probably check their blood pressures at home.
I know we check it. We've been checking it for some time in the office. We have the Welch Allen 24 ambulatory blood pressure monitor, but of course they come to us. There's logistics around doing home visits and having to drop it off. But actually, I'm not pleasantly, but surprised at how much you can really pick up from doing that 24-hour blood pressure. And a lot of times we'll see people where their blood pressure is supposed to dip down at night. So you see that they're non-dippers. And that's a good sign of, first of all, if they're non-dippers, that could be a sign of not having enough melatonin. So sometimes we give them melatonin, but it also it helps us catch sleep apnea often, which we don't want to miss. So tell me, so when you have the patient that you're giving them instructions, they have their ambulatory, they have their own blood pressure cuff at home. How many times do you tell them? You said 5 times a day. What is the instruction that you give them? How do they take it? And do they check it again? Do they check it once? And if it's high, do they wait 5 or 10 minutes and check it again? What instructions do you give them? And for how much amount of time before you see them?
Yeah, so I try to make it digestible. So I tell them to check their blood pressure, both arms, about 2 to 3 minutes apart, 2 to 3 times a day for the first couple days. But I want you to vary those times of day, just like we do for blood sugars, right? Sometimes they're postprandial, sometimes they're fasting, sometimes they're bedtime. Same thing for blood pressure. I want to see it when you're calm, cool, and collected. I want to see it when you're angry and frustrated. I want to see it when you had an easy commute from home. I want to see it right after you get home and had a terrible day and the traffic was 2 hours. So show me what's the best you can be and what's the worst it ever gets. Give me the whole range. And then after I get 2 or 3 readings for 2 or 3 days, then I let them slack off a bit, and I just have them usually at the initial time when we're in the first month, when we've just recently assigned a possible elevated blood pressure or an elevated blood pressure, possible hypertension diagnosis, I'll probably get 30 readings in the first month. After that, we're doing a couple times a week. I don't think we need to be as aggressive.
And then how do you interpret that? Let's say that on their stressful days, it's going up pretty high, but on their not so stressful days, it's looking good. What do you do with that?
Yeah, so that's an opportunity for therapeutic lifestyle interventions to see what we can do. We know that nerves that wire together fire together. So the more the patient stays in a parasympathetic state, the more they're going to be able to attain a parasympathetic state. So someone who shows me that they can achieve normal blood pressure readings much of the time and only spike from time to time, I'm going to ask them to work harder on meditation, prayer, gratitude, maybe lavender, maybe gargling, things that stimulate their parasympathetic nervous system. Try to get them in that state more often so it is more enduring. I don't want to give them medicine if I don't have to.
What blood pressure reading are you considering hypertension? Because you said old numbers, new numbers.
Yeah, so when I was in school, 160/90 was an acceptable blood pressure reading for our seniors. Just because it's common doesn't mean it's normal. And the newest guidelines assign a hypertension diagnosis at 130/80 or greater. And I think that it's very helpful for all of us to use the word maximum acceptable rather than the word target. So if I say your target blood pressure is 130/80, and you come to see me and your blood pressure is 136 over 84, it's pretty close. We're not going to move the needle much. But if I say your maximum acceptable blood pressure is 130 over 80, we have a different tale to tell. And we're much more aggressive at doing things. Those things aren't always medication. In fact, I don't like to use medication. I feel like it's a bit of a failure on my part if I need medication. But it's an opportunity for us to say, time for more aggressive monitoring, time for more aggressive treatment, maybe more testing of micronutrients, maybe testing of hormones, maybe testing of sleep apnea. And probably that's one of my biggest secrets, is to screen all hypertensives for unidentified obstructive sleep apnea.
And you mentioned a good point about seniors, that and traditionally what they would say is that because seniors, they have more stiffness over time, and because people 65 and older, they have more of a chance of their blood pressure at rest. You get them down to normal, but then they stand up and they have that orthostatic hypotension, and they can end up having end organ damage. I'll tell you a couple of things that we look at for that is before we do act and give someone a blood pressure medicine, we are going to get them to stand up and check their blood pressure, especially someone 65 and older, so that we make sure that it's not dropping too low when they stand up. And then we'll have them come back and do the same thing. And actually, a little pearl that not too many people know about is that just like you can get a troponin, you can get, or I'm sorry, just like we check CRP to see if someone has inflammation, high amounts of inflammation. We can do a high sensitivity CRP to see if they have chronic inflammation. You can do the same thing with troponin. So if when troponin is high, that means that they had damage to their heart, they're having a heart attack, but you can do a high sensitivity troponin. And in those elderly patients that you're wondering, am I getting their blood pressure too low? Because it's not going to be the same in your office as it is going to be at home, as it is when they're sleeping. Is it going too low? If that high sensitivity troponin is elevated, that's a sign to back off on the medication. So let's go into some rapid fire. So now we talked about it. We talked about how many times do you want to test it before you make the diagnosis of hypertension?
Yeah, I don't think there's an actual official number that I've seen anywhere in the literature. I'd say enough. Get a good smattering. High days, low days, probably over a month you can get it, unless it's an atypical month, right? Then we might even need longer.
Okay. So let's talk. So you have a person, you're following them, their blood pressure's high, and all of this, and you have determined this person, you have hypertension, and
Yes.
You make the diagnosis of hypertension, and now you say, all right, I need to do a workup. So we've checked all the blood pressures, workup. Let's say your patient keeps checking it, and they start getting obsessed with it, and it's now making their blood pressure go even higher, which that does happen too. Sometimes I got to tell them, just stop checking your blood pressure. I'll check it. Just leave it alone. Right. So
Yes.
Now you have this patient in front of you, and now you want to get a workup. What blood work are you going to do to look at that person with hypertension?
Yeah. So to me, this is an underlying risk factor for the presence of atherosclerosis and cardiovascular risk. So now I'm taking a deep dive into their oxidative stress, inflammation, and advanced lipid numbers. Great. So we're looking at myeloperoxidase, Lp(PLA2), F2-isoprostane. We're looking at oxidized LDL. We're looking at LDL particle numbers, LDL particle size. I'm looking at apolipoprotein B. I'm looking at lipoprotein little a. I'm looking at magnesium. I'm looking at potassium. I'm looking at uric acid. I'm checking for sleep apnea. I'm looking at hormone levels. I'm looking at vitamin D. I'm looking at B vitamins. I'm looking at zinc and copper. I'm looking at thyroid numbers. Obviously, hyper or hypothyroid, both can lead to hypertension. It's a deep dive.
That's great. So
blood work.
Once again, to those practitioners that unfortunately haven't seen the functional medicine light, they hear this and they're probably like, what the heck is happening? To me, though, as a functional medicine practitioner, as you're spitting off myeloperoxidase and these names, it's like you're singing to me. This is like amazing. Well, keep going. and for y'all that are watching this, make sure you rewind it and get this panel because you're mentioning some really good causes. You mentioned and we want to rule out sleep apnea. You can give them a home sleep test. And if you really think they have sleep apnea, you can send them to the center. Comprehensive thyroid, advanced lipid, which you mentioned, looking at oxidative stress or rusting, glycation. Did you mention glycation?
I didn't, but hemoglobin A1C, we absolutely
Right.
look at, and a 2-hour glucose tolerance test. Because in some studies, hemoglobin A1C will underestimate impaired glucose tolerance by 58%. So we'll miss it very often if we're only using the hemoglobin A1C. And furthermore, there's a gender difference. Men manifest impaired fasting glucose as one of their first markers of metabolic syndrome. Women manifest impaired glucose tolerance 2 hours after we eat. Are you checking 2 hours after they eat? Most people do not. In my office, we do a 2-hour glucose tolerance test with insulin and an insulin resistance marker as well.
Are you checking the insulin resistance score at all? Or are you just
cardio
picking...
IQ, insulin resistance?
No, I really love that test. It's something I've picked up a lot taking a look at that.
And then there's one other test that I do that's not blood, it's saliva. And that's a salivary diagnostic test for oral pathogens. Okay. I'm not a dentist, but I play one on Zoom calls. And the role that periodontal pathogens play in driving insulin resistance, in driving up lipopolysaccharide levels in the bloodstream, and increasing plaque directly and indirectly by at least 3 different mechanisms is well known. And so if we are missing periodontal pathogen burden in the mouth or periodontal disease as a driver of not only hypertension, but also cardiovascular risk, heart attack, stroke, Alzheimer's, and cancer risk, we have missed a huge opportunity to change the trajectory of the patient's lives.
Beautiful. Because basically, for those of you that did listen to me and tune in and not skip around, yes, you did hear her right. She is saying that the bacteria in your mouth there is a correlation between the bacteria in your mouth and blood pressure and other conditions as well. So tell me about the test that you do. Which test is it? Which one are you doing right now?
Yeah, so there are several tests on the market for screening periodontal pathogens. They also have some advantages and some disadvantages. I do some tests from a company called Bristle because they are over the counter, they are direct to consumer, and they sell in packages. So you can get one and then a follow-up and a follow-up across the course of a year, which is a really good idea to see if the therapeutic changes you've made in your home dental care routine and working with your dentist and whatever it is they're doing, is it moving the needle and changing those pathogenic flora? And there's very specific, very sophisticated treatments for different bacteria and combinations of bacteria. Furthermore, we're beginning to understand that some of the most resistant cases of periodontal gum disease are driven by a biofilm that contains viruses and yeast, not just bacteria. Bristle checks for these viruses, checks for these yeast. There's another company called Oral DNA that checks 9 different species of yeast in their their test is called Oral DNA is it's escaping me. Anyhow, the company's called Oral DNA.
Okay.
But the one I'm using the most now is from Spectrum, and it's called Simply Perio. And I like it because they check a couple viruses. They look for CMV and they look for HSV, herpes simplex, as contributors to the biofilm, along with a couple of yeast and all of the red complex oral pathogens.
Could you briefly tell us why is it that bad bacteria in the mouth or having dysbiosis or not having the right microbiome of the mouth would cause hypertension?
Yeah. So there's several reasons, but one is, remember, the gut begins in the mouth. What functional medicine practitioner doesn't say, treat the gut first, treat the gut first? We swallow 1 to 2 liters of saliva. So we want to make sure that we're getting those mouth bacteria right. that this little lipopolysaccharide, LPS, my friend Lindsay Berkson coined the term little pieces of shit because LPS is from gram-negative bacteria, which we think about in poop. But many of the oral pathogens are also gram-negative bacteria. Every time we chew, if we have gum disease or a periapical abscess, we can drive that lipopolysaccharide into our bloodstream. It's a driver of oxidative stress. It'll raise our blood pressure. So that's one way, lipopolysaccharide. The second way is that one of the mouth bacteria, who has a long name called Porphyromonas gingivalis, we call him PG for short, he has this nasty habit of making plaque. He secretes something called phosphorylated dihydroceramide. It's wax. PG makes his own plaque. That's fine when he lives in your gum tissue because we expect plaque on our teeth. But what we didn't realize until recent science is that when those PG bacteria hitchhike on blood cells, red or white blood cells, and get through the bloodstream, they can make plaque anywhere they land. They can make plaque in the arteries. They can make plaque in the brain. So plaque will obviously stiffen up the arteries and increase your risk for hypertension. So Porphyromonas gingivalis as a second way through phosphorylated dihydroceramides that can drive blood pressure. And the third way is when we get a dysbiosis of the mouth and we don't have the right bacteria living in the crypts in our tongue, we can't convert nitrate to nitrite the way that we're supposed to. These mouth bacteria are responsible for raising our pool of nitrate so that we can use it to make nitric oxide. And nitric oxide is that miracle mouth molecule that's so important. It won the Nobel Prize. It's a gaseous signaling molecule, but it's used everywhere in our body. And one of the many things it does is it dilates blood vessels. And if you don't have enough pool of nitrate, you can't make nitric oxide and you can't lower your blood pressure normally.
Right.
So,
now, this is not the stuff that people are going to get on just a regular medical podcast. This is amazing. No, thank you. So I had worked for years teaching on IFM's module, cardiometabolic, and I hadn't fully wrapped my brain around the whole nitric oxide connection. And I ended up stumbling upon it, and I started working with Human N, the company that makes Neo40 and Neo40 Professional. And I first was very skeptical, and I started trying it out in patients, and I started seeing patients doing well, and it made me really jump down that deeper dive. But yeah, if you can't convert nitrate to nitrite, then what happens is that you can't make that through that pathway, you will not make the nitric oxide. And that's what it does. We give them nitrite, which now you don't need the bacteria, and then someone that knows what they're doing will help them get the good bacteria or the good flora in the mouth back. But I want to ask you, so you're going to work on the mouth. You're going to work.
Can I share a quick story that maybe helped drive this point home? I had a patient that was referred to me by her dentist because she hadn't been to see any healthcare practitioners in over 10 years, including a dentist. The dentist checked her blood pressure, which I think all dentists should do. And it was like 200 over 110. And she said, your blood pressure is too high. I can't do anything for your horrible mouth that really needs some serious cleaning. Go see Dr. Campbell. So she came to see me, and I put my tongue depressor in, and her fetid breath was terrible. So I knew that she had terrible dysbiosis of her mouth. I put her on Neo40 lozenges. I put her on a toothpaste, dental sidin that has some bacteria and antibacterial herbs in it. And I put her on, third thing, nitric oxide. Oh, a probiotic, an oral probiotic called ProBioPro. And she called me back in a week and she said, this toothpaste is amazing. I love those little lozenges too, but my blood pressure is now 140 over 70. I think I can go to the dentist now in a week. So all we did was shift her microbiome flora and helped her nitric oxide pathway. And in a week, she showed a significant difference. So you, as a healthcare practitioner, can make a dramatic change in your patient's risk with a couple of simple strategies directed at the mouth to treat their hypertension.
And I can tell you, most people aren't looking in the mouth. Most people are saying, leave that to the dentists. So you talked about magnesium. So obviously magnesium supplementation. From a supplement point of view, what are your maybe top five? Let's get away from the mouth now. Five top supplements that you would actually put in the mouth, so we can't fully get away from the mouth. What are your top five supplements that you've seen may help people with high blood pressure?
So vitamin D, A, and K, I use a combination. They're all three together. Magnesium's probably my next go-to. Potassium is probably my next most common thing. A multi-mineral that's got magnesium and potassium in it. And I think that's five: A, D, K, magnesium, and zinc.
We got our five. And I like magnesium. I like them taking it a couple times a day. I'll use magmalate or maglysonate. And ubiquinol, I'll use CoQ10 or ubiquinol. And I actually will check the
Fantastic for the
CoQ10.
gums. CoQ10 and toothpaste is really good for gum health.
Oh, that's good to know. I check a CoQ10 level and I want to get it greater than 3. So sometimes I'm
Wow.
upping that dose. Yep, for
Wow.
the cardiovascular benefit. So now what about medication? What medication, when somebody's diagnosed with hypertension, what are your go-to medication?
Ramipril is probably among my first choices if they have atherosclerotic vessel disease, in part
Okay.
because of the HOPE trial, right? So we want to see if we can move the needle, reduce their risk for, it's an ACE inhibitor, it's well tolerated, very few side effects, most people handle it. They're African American, they don't do as well on ACE inhibitors. They may do a little better on a calcium channel blocker, so I may use a combo calcium ACE in African Americans. I think that I use a fair amount of diuretics because they're easy and cheap. Hydrochlorothiazide, chlorthalidone, I use those still a lot. And there's so many. It's like, what else are we treating?
Right.
It's always personalized. Are they male? Are they female? Are they dippers? Are they non-dippers? Are they?
No, we have a lot of tools at our fingertips. I really like telmisartan because telmisartan, there's data that shows that it helps prevent Alzheimer's. It's the ARB class that binds the most tightly to the receptor.
I'll have to look at that. I use a lot of olmesartan, but I don't use as much telmisartan, so I'll take a look at it.
So what I like about telmisartan, I actually put a spreadsheet together of all the benefits of the ARBs, and telmisartan just was ranked the top for most of that, for most things, including the time I'll use losartan would be when they have high uric acid, because high uric acid can also cause high blood pressure. But the interesting thing about telmisartan is that it's a PPAR gamma agonist.
Ah.
And what that does, that class will help with metabolic syndrome. And then I actually stopped using hydrochlorothiazide and chlorthalidone because there is indapamide. Indapamide is a diuretic that is, but it doesn't cause the metabolic syndrome that you see with the others. But we have our medication, so we're not opposed to medication in functional medicine. We use it when we need it, but we're working on the foundation. That was a great overview, but now, Dr. Campbell, it is time to spill those functional medicine organic beans. We want to hear your clinical experience. So this is the clinical experience share. Tell me, what are those things? What are the things that you have seen in your practice? What is it that you have picked up over your years of experience that you're not going to get from just going onto artificial intelligence or Google? Or what have you seen that in the management of hypertension that we really need to know about here?
To unlock additional premium content, including the deeper dive in this clinical topic, leadership and speaking tips, charting and efficiency pearls, and business mastery as a functional medicine practitioner champion, be sure to check out our mastermind and other membership programs at www.fmpessentials.com. Hey everyone, we hope you're enjoying the FMP Essentials show so far. Pretty amazing, isn't it? Remember, if you're part of our mastermind, don't miss out on our exclusive bonus clinical content. That's where we take a deeper dive look at personal experiences and real-world insights that you can't just get from a book or from looking on AI. It's where we really get into the nuances that make a difference in your practice, the experience of the guest of our show. Thank you for watching, and we hope you enjoy the rest of the show.
At FMP Essentials, we strongly believe that giving back and making the world a better place is everyone's responsibility. So how do we, as practitioners, how do we make a difference? So I have some questions. The first, what are some impactful ways that you believe that practitioners can contribute to their communities?
Volunteer work. It's simple. I always believe that when we do volunteer work, we get more than we give. And I think that we should do some form of volunteer work that's not directly related to medicine. We're really boring people if we only do medicine 24/7, and I think we need to branch out. My favorite thing to do is Habitat for Humanity. When I was in high school, I was on the stage construction crew. So I did technical theater, sets and construction and lights and all that. And I learned how to use a hammer and a table saw. And since then, since I have been 18, I've been a Habitat for Humanity volunteer. So I go out and do sometimes blitz build a week at a time. Sometimes there's a chapter, my husband's a school teacher, there's a Habitat Women's Build at his school. So usually I do that in the spring, and it's women only. All women construction volunteers building homes for families of women. So that's one thing. It's simple to be a volunteer, and you pick what you like, but I think it shouldn't be something in medicine.
I like that. I like that because we tend to identify with the medicine and then get disconnected from other people, from the rest of the world. Can you share with me? I happen to know that you have a unique way of giving back, and I was very touched and very inspired. And if anything, I would love for other practices to copy your model.
I would too.
Good, very good. No, but
Let's talk about it.
Let's talk about it. Yes.
So I came from a background of community health center. I did 13 years practicing indigent healthcare. And I learned a very valuable lesson doing that. Free is valueless to most people. And so it always bothers me when medical doctors give away their services free. And I feel like it just has less value when it's free. It is so labor intensive for us to get to do what we do. And 30 years of experience is valuable. I really don't want to give it away free. But I also think that everyone deserves healthcare with dignity. So how did I figure out how to marry that? I used my Habitat for Humanity experience. When someone becomes a homeowner for Habitat, rather than pay their down payment for their house in cash, they do sweat equity. They actually have to work on their own house or someone else's. So when they collect whatever your chapter decides, 100, 200, 500 hours of sweat equity, that's their down payment. So when I started my practice, I told my husband, I don't want to just serve rich people. I don't want to be the doctor to the Braves wives. I want to have a broad swath of my community. So I'm going to create a program that tithes to my community. Tithe meaning share 10% of what we earn with the Lord. 5% of the cash that we earn every month goes into our tithing checking account. And once a month at staff meeting, I tell my team how much money we've earned, and everybody gets to make a donation to the charity of their choice in our name from them. So this allows my front desk receptionist, who's the lowest paid person in the office, to make a large donation to charities of her choice in her name. And it gives her great dignity and pride because she knows she earned that profit. She helped me earn that money to give away to those people. So empowerment for your team is one of the business strategies that's allowed me to have the same front desk person for 9 years, the same phlebotomist for 14 years, the same office manager for 19 years, the same nurse for 7 years, right? Because I empower them with ability to do their job independently and empower them to share in the practice benefit, the practice rewards. The second 5% of my patients, so that's tithe, right? 5 is in cash, 5% is in service. So if a patient needs me but can't afford me, they're offered a scholarship membership. And so rather than pay me in cash, they're given a scholarship membership log sheet. They go out into the community, they do 15 hours of community service. They get that signed off by their supervisor, and they turn it into me as if it were a check, and they've just earned 3 months of unlimited office visits in the membership as if they'd paid me cash. So this is a win. The patients win because they get my care with dignity. The community wins because it gets 15 hours of community service for every one of my scholarship patients. And I win because I quantify the amount of charity care that I do without giving away the bank. Because like you and me, we're tempted to just do it free for everybody. We don't care. But then we can't send our kids to college or pay for our car or go on vacation, the things that we need to fill our tank so we don't burn out. And so this scholarship membership has worked beautifully in that regard. The patients get their care with dignity. The community gets volunteer hours, and I get to quantify how many patients are on scholarship. I had one patient, she was probably 85 pounds on oxygen, a little tiny COPD, and she said she couldn't do much. And I do say, if the patient is too sick or infirm to do their own hours, a community or family member can do them on their behalf. So they can earn those hours that way. But she said, no, I don't want anybody to help. She goes, I can still knit and crochet. If I make newborn baby caps for the newborn nursery, will you allow that? If I count 15 hours and I give those caps away to the newborn nursery, will that count as my charity hours? Absolutely. So she was so frail, the only thing she could do was sit in her chair and crochet, but she got her scholarship hours that way.
And beautiful, so inspirational. I'll tell you, so part of being successful in functional medicine is that we figure out a process, right? We do all of this information, we find out what's causing it, we come up with a process. And being successful overall, really the most successful people have a process for doing that. What you're doing is you've created a process to help those people that cannot afford it, but you also give them their dignity because they're working for it. And also, I remember when I first started, I remember we had a weight loss program, and it was a bunch of shakes and that were part of the program. And I remember I would give people $300. I would just give it to them, and they wouldn't do well. If I gave them a discount and it was hard for them, they would do well. So the fact that they're working for it, then they're not going to take you for granted. But I also really love that you're giving a percentage, not only giving a percentage to these organizations that need it, but you're letting your staff see that and be part of that. And now they're getting some of that good energy that they're putting out. And you have it systematized. So it's not something that you're giving charity sometimes and you're not other times. And giving charity, there's so many, I'm sure we could go over just all the benefits of that. But being able to give to others stops us from having that money in our heart, and it helps us place money in our hand, which is where it's supposed to be. I think most of the problems of the world today, if you look at the horrible state the world is in, it's because money is in people's hearts, and that's what they're going after. What about specific organizations that help the functional medicine cause? Are there any specific, like, I know that I like donating and encouraging donating to the Institute for Functional Medicine. They're a non-for-profit. They do a lot of work and creating programs, and they really put a lot of time, effort, work, and it's not inexpensive to put these programs on. But what organizations do you feel like are making the world a better place from a functional medicine, lifestyle medicine, personalized medicine point of view?
Yeah. So I do donate to IFM, and there's two others that I donate to on a regular basis. One is the International College of Integrative Medicine, ICIM, also a 501c3 nonprofit education organization, as is AOSH, the American Academy for Oral and Systemic Health. And AOSH has a mission to unite medicine and dentistry together. And I think that in my journey, what I learned was the number one hidden risk factor to the number one killer in our country is oral health. And until we recognize the role that the mouth plays in hypertension, cardiovascular disease, heart attack, and stroke, we're missing a major contributor. And AOSH is designed to teach students, residents, physicians, dental hygienists, dentists, the entire realm of healthcare practitioners about these connections, including airway, because without airway, we got to have airway. Airway's first. If you're not breathing at night, nothing else is going to go well. We have opportunities to donate to these organizations to help them spread the word to as many practitioners as possible.
Thank you so much for your generosity, for your encouragement of generosity. Thank you for being generous with your time today. Yeah, we could go on and on. This is just a small fraction of the wisdom that is buried within the being called Ellie Campbell, Dr. Ellie Campbell.
I've been doing almost 40 years. You'd hope I'd have some wisdom by now.
Oh, you got it. You got it. So, Dr. Campbell, how can functional medicine practitioners, how can they stay connected with you?
So I have my practice website is campbellfamilymedicine.com. We have a Facebook page there as well. My book is The Blood Pressure Blueprint. It's available on Amazon, and I have a website for it, bpblueprint.com. They could email me. I don't promise that I'll answer right away, but it's ellie.cfm@gmail. That's ellie.campbellfamilymedicine, cfm@gmail.com. So they can shoot me an email. I'll do my best to answer back.
Nice. Thank you so much, and look forward to next time we meet. Actually, do you want to tell people about the conference that is coming up in a year, so they have time to prepare for this?
It's a year from now, August of 2025. Yes. So mark your calendar. The International College of Integrative Medicine, I'm the program chair designing a conference called Chronic Kidney Disease, Identification, Prevention, and Reversal. You're going to hear some speakers who have gotten patients off dialysis. Kidney disease is identifiable at much earlier stages than we recognize. It is treatable and reversible in many cases, and even in the most severe cases can sometimes be reversed.
Awesome. And we will make sure that we share that link below so that there's no excuses. There is a year to get ready for this. So even if you're watching this late.
And it'll be in Atlanta, here in my hometown. Yes.
Dr. Campbell, thank you very much.
My pleasure.
Hey everyone, I'm Dr. Yousef Elyaman. We hope you enjoyed the show. For more exclusive content from this interview, check out our FMP Essentials Mastermind. Make sure you check out our website at www.fmpessentials.com for our blog and other content. If you enjoyed this show, please, please, please subscribe. Give us a like. It helps way more than you could imagine. Thank you for watching. Follow us across all social media platforms at FMP Essentials HQ. Please don't forget to share this with your practitioner friends, and we'll see you in the next episode.